easy to handle, moldable. It's most important to have good bones. Patient's bone and the graft have become one. No gingival recession on the labial side. Sufficient volume. It will be useful and effective in clinical cases. It's nice to see you. My name is 장호열. I run 장호열 Dentistry in Daejeon. I'm using a variety of MedPark products in my practice. I performed an immediate implantation with GBR. By using S1 graft and the COLLA membrane, it was a great success and very satisfactory. Through this case study, I hope to share a lot of good information with you today. In this case, as you can see in the picture, tooth number 21 had a severe periodontal problem. Lots of shaking, and it's now shown here, but there was a lot of pus. Around gum as well. Mobility was severe, so there was no other option but extraction. According to X-ray and Panorama, especially CT, there was no bone left on the labial side of the teeth. You must have your own way regarding a treatment method or a plan. But for me, I prefer the immediate implantation right after the extraction. Although this case had an extremely negative bone situation, I still plan to do the immediate implantation. With the tooth extraction, I plan to perform an immediate implantation. And by using MedPark's S1 graft, I plan to do GBR as well. I performed the extraction first. As I diagnosed before the surgery when I opened the flap, I could see there were no bones on the labial side. Clinically, cases like this are classified as dehiscence defect. If you don't have enough bone like this, naturally there's low healing potential. We need to exercise caution and use better and correct materials in a case like this. But if we do so, I believe we end up with good results. Before the surgery, I made the implant surgical guide using the patient's teeth scan and CT data. With the surgical guide placed in the oral cavity, I started drilling for implantation. In anterior cases like this, I generally use an implant guide, connected a healing abutment. I plan to do it in one-time procedure. The initial fixation wasn't that great, but not bad either. On the labial side of the implant, there was confirmed dehiscence defect. How do I do the graft in situations like this? There may be various surgical techniques and materials for it. I decided to use the S1 graft in this case. Even before I started using S1 graft, I liked using fibrin glue extracted from the patient's blood to create a sticky state of bone for grafting. In this case, I used more convenient S1 graft. S1 graft, as you may know, is a bovine-based grafting material, and when it's mixed with saline, it turns into a handy moldable state to be used in bone grafting. It will be useful and effective in clinical settings. In this case, I manipulated it into a form in this moldable state. As you can see from the picture on the right, this was very easy to handle with something like a PerioSteel elevator. Knocking with it for a few times was enough for three-dimensional augmentation. As you can see on the labial side and on the vertical side, it could be rebuilt into a rich bone state. Whether to graft on the top or not could be debatable. But I decided to use MedPark's COLLA membrane, which is a bovine-based membrane. I cut the membrane in the shape of the graft. My personal advice on grafting is make sure the membrane doesn't go over the incision line. If it goes over the incision line, wound dehiscence may happen and also the membrane may be exposed. So I made it much smaller and placed it. I sutured it in the way that there wouldn't be too much tension in the flap. There was an area of low tension due to a releasing incision. But with this type of suture, it became very secure. The sutures need to be secure in order to keep the flap unexposed. That's important. Reviewing Panorama and CT after the surgery, you can see the labial side bone, which had been completely absent before surgery, has been richly rebuilt. After the procedure, because it's anterior and per patient's request, I've made a temporary prosthesis for aesthetic restoration. I've used an oral scanner to make an impression, and through CAD design, I've made a Maryland type of temporary prosthesis. I was able to affix the prosthesis using the cementation to the teeth on both sides. What I consider important here is properly pressing the swelling and gingival area. Proper pressure is important to preserve the proper form of the papilla, and I believe a fixed prosthesis is more effective than a removed temporary prosthesis for this purpose. Let's look at the progress. This is a picture after 2 months or so. As you can see, state of soft tissue and volume of hard tissue have significantly improved and look good. When Implant's ISQ value was measured, it confirmed that the implant was fixed securely. I figured that it no longer needed to be fixed to the teeth next to it. But I could use a prosthesis that would strengthen the implant. So I removed the healing abutment and made the impression using oral scan after connecting scan abutment. Temporary material was used for the prosthesis and fitted to the fixed prosthesis on the implant. There wasn't quite enough strength here because the implant hadn't completely adhered to the bone yet. With a lack of strength in upper and lower teeth matching, it wasn't the best aesthetically, but I could have fixed the prosthesis firmly this way. To reproduce papilla, an appropriate pressure on soft tissues should be applied. This way, a soft tissue can be rebuilt nicely, I believe. This is a picture after 3 months. That is about a month after the temporary prosthesis was placed. You can see, with a proper pressure, soft tissue was formed in a good appearance. And I think because of these nicely formed papilla and crater made the final prosthesis production super easy. Because you just need to make it to fit here. By attaching a scan abutment the same way and scanning for the final prosthesis, in my case, I do everything digitally, so I used CAD design and made a final zirconia prosthesis. I believe the patient and I both were satisfied with the result after the setting. As you can see, there is no gingival recession on the labial side. Sufficient volume, the prosthesis, and the color. I believe the result was satisfactory for both patient and myself. Compared to the pre-procedure, I consider this was a successful clinical result. By comparing the x-rays, one could see there was no bone on the labial side before surgery, but there was enough bone transplantation using S1 graft. And after the prosthesis usage, you can see there has been a significant bone remodeling. One thing to mention is when you look at the form after the prosthesis, you can see that the bone shrank a little. Therefore, I suggest you do enough bone grafting with the potential shrinkage in mind. Clinically speaking, about 20 to 30% overgrafting of bone may be my clinical know-how learned from experience. When you extract a tooth with lots of inflammation, it tends to bleed a lot. But once the tooth is extracted and surrounding inflamed tissues are thoroughly removed, usually bleeding decreases. I think in cases like this, removing the inflammatory tissue cleanly is the crucial step for the immediate implantation procedure. That way, the bleeding won't be a level that would hinder the surgery. Precise incision, very gentle flap lifting, performing the procedure without trauma to the site would be key factors for the procedure. Absolutely. If the graft is all independent, if it's like independent particles of graft floating around, I wouldn't have had a graft you see in the picture right now, because the particles would have been on other teeth, on the tongue, and everywhere else in the mouth. I believe a graft that's somewhat glued together is definitely more convenient to manipulate. If I want to do the old way, I need to draw the patient's blood. It is inconvenient for the practitioner, but it may also be an added burden to the patient to be pricked one more time. It would be okay if we do a good job first time, but if we have to do it multiple times, no patient will like that. First and foremost, though, the surgery can be done neatly, minimizing side effects after the surgery, such as edema, would be the biggest point. Bottom line is, having bones formed well would be the patient's main concern. So, in my opinion, the most crucial factor for successful grafting is having the graft well fixed in the surgical site. And maintaining this space is especially important. In this respect, By being well fixed in the surgical site and not moving around, S1 graft creates a suitable environment for bone regeneration. With a good result, it's only natural that the patient is satisfied. I sometimes use a membrane and sometimes I don't. If I needed to do a 3D remodeling, I use titanium mesh, which is an excellent material for space making. The reason I used the COLLA membrane in this case was because I wanted to see its claimed benefits. COLLA membrane has a very dense collagen bridge, and it's absorbed at the appropriate time inside wounds and flaps. Not too soon, not too late. Degradation. I wanted to see if it works with my own eyes, so I tried it. The result was as fantastic as I expected. This was truly a very satisfying case. I look forward to using it more in various situations. The cases I consider membrane is necessary are with no contained defects, not contained defects. In other words, the cases where bone cannot be fixed, but it's at risk of flowing down. In such cases, I think we should use a membrane. Generally, such cases demanding 3D dimensional bone reconstruction, the form needs rebuilding. For example, if the defective form is a contained defect, I don't think a membrane is a must. I believe S1's sticky property is enough for graft fixation. Let me show you through a schematic diagram. When I do a bone graft, this schematic diagram is fundamental. I focus on the defective form. Depending on whether the defective form is contained or not contained, it'll help me to decide whether graft will flow down or not. Simply put, how much wall remains around the implant becomes an important factor. For example, if you have 5-wall or 4-wall, you can use any graft. The need for a membrane is reduced because it won't flow down. But from 3-wall, especially for 1-wall, it is a non-contained defective where the graft can flow down. Cases like that, I think we need to use a membrane. It means for contained defects like 4-wall or 5-wall, you can just use grafts such as S1 with no problem. But in cases of 3-wall, 2-wall, or 1-wall where there's no wall, using a membrane with the graft will be much more beneficial in stabilizing the wound. Deciding where you should use a membrane and where you shouldn't resides in personal judgment, but this is my opinion. In today's case, as you saw earlier, the whole labial wall was destroyed, and because it was an anterior area where aesthetics was important, and most of all, the stability of the wound and graft fixation were vital, so I decided to use a membrane. Strictly speaking, to know if the new bone will be formed or not can only be determined by a biopsy. But the truth is that doing a biopsy on a human body is not easy, so I usually analyze X-ray patterns instead. Here on the PPT, we can analyze CT before surgery, and after prosthetics. After surgery, CT shows the original bone and the graft on it can't be said it's one bone. There's discrepancy. In the CT after prosthetics, by the way, the prosthesis was done 3 months later. You can see the patient's bone and the graft have become one. Because it looks like a same tissue through X-ray, we can hypothesize that there has been a natural bone remodeling. Of course, it would take some time for the bone to become strong. Since it's only been 3 months, it's not a completely hard bone yet, but I believe it'll become stronger as it functions more and more. Through X-ray comparison, I am confident you would agree with me that the bone is well rebuilt. This was my case study of MedPark's COLLA membrane's utilization with a successful result. I'm very satisfied with the experience. In reality, many colleagues ask me which graft is the best or which membrane is best. I believe there is no one right answer. It is up to your style and your care concept, but if you are only looking at the clinical convenience rather than the existing particle type, A sticky and moldable form with only saline to apply to the graft site would be welcomed by any clinician for its clinical practicality, I believe. Generally, membranes being easily ripped or torn or being absorbed too soon is a concern, but this product performed superbly in my experience. Also, there was no problem such as impaction in the wound. It was kept well, and most of all, it worked wonderfully in bone formation. I'm confident that you would agree this is an attractive product. If you give S1 and COLLA membrane a try, I'm sure you will also have successful GBR cases, maybe even more satisfying cases than I have. Thank you very much for your time.